So now I would like to invite Prashanth to give his presentation. Prashanth is experienced at many levels in the primary healthcare systems in India and is now a student in PhD at the Institute of Public Health in Bangalore and is studying the capacity building of health workforce. So Prashanth, please, you have the floor.
Hi. I would like to engage with you about questions really, because I think, frankly speaking, universal coverage is about questions. Some of them are unanswered and some of them are even unasked. So if we ask, like, whether we can use rafts to cross the Pacific, that is a research question. So, well, Thor Heyerdahl, a Norwegian explorer, tried to answer that question, and for that he built a wooden raft and he went across the Pacific. So the answer to the question really depends on whom you're asking. So if you ask the person who did something successfully, you get a way to do something successfully. If you ask somebody who could not do it, you get another way to how to fail in doing a problem. And I think increasingly in health policy making, we are falling for this policy trap. Because increasingly health policy makers are asked to choose a small intervention that has worked in a village in South India and now let's scale it up across the country. And what they miss is the detail and they export the model. And you have beautiful policy briefs on how to expand community health insurance across the country. So, I mean, why is this, at least for India, because it's a really big problem. On one hand, we are a nuclear power and, you know, Obama comes in and stuff. But on the other hand, you have mothers dying, you have under 5 anemia, at 75% of all our children are severely anemic. So it's a land of severe inequities. And we still have to answer questions of basic access, universal access, coverage, how deep is really very, very far away. Here, for example, one of the ANMs in a PhD I was working in had to cross rivers she had to go across rivers to immunize people, and she used to do that once in 6 months, understandably. So, I mean, so the problems of basic access, when they are not solved, how can there are so many technical sounding reports and things that are giving panaceas for everything? I refer particularly to public-private partnership in primary healthcare, for example. There's a slew of such projects happening across the country. People are saying universal coverage, here it is. Here's the private sector, and come on, let's scale it up across the country. I had the opportunity to work as a medical officer in one primary health center that was under PPP. Yes, we did show some success. I mean, we showed that acceptability of services was better. We had better utilization of services in the PHC where I was. Compared to the nearest government PHCs, we put in a lot of innovations, we had motivated health workers. Across a decade, the PHC showed a clear decrease in maternal, in infant and neonatal mortality. And we did a lot of things that really worked. And this model was of course in 1996. PPP was not a big word then. Today, across the country, you have a slew of PPP models that are based on a few success stories here and there. So, one wonders, what is the sort of evidence and research that is really going into such sort of massive scale-up strategies? And have we considered why some things work and how did these work? And yes, when we try to look at that, in the primary health centers that I studied eventually for my master's thesis, I found several contextual factors, several things like motivated staff and a beautiful environment to work in that are really critical for some of these magical innovations to work. And what about studies of where PPP did not work? There is nothing. There is really nothing because it's not fashionable enough to publish something that failed. You know, it will never reach a peer review journal anyway. And this really is the sad story of health research. That things have to be a bit fashionable, things have to subscribe to a certain ideology, and the actual reasons that make an intention work get lost in the model. In Gumbadi, for example, the fact that a non-governmental organization with with strong value component and a mission-driven attitude made it work is an important factor neglected in the scale-up. So is the nature of this private sector, for example. Private sector comes in all technicolor shapes. It includes the beautiful corporate building to a 3-man NGO in a forest area. So, when we make up these strategies, where is the evidence coming from? What sort of private sector are we talking about? So I compare this to this model of the keyboard, QWERTY, which we all use, which is not the most efficient keyboard layout. It's well known that the Dvorak model of keyboard is the most efficient one. It did not come in. because there are no advocates and the markets were already used with a QWERTY typewriter. So sometimes inefficient models persist because there is nobody to tell what was more efficient. And that, I think, is critical because of primary healthcare. There is no real market. There is not all these huge number of private providers wanting to provide preventive services and health promotion. And I think that is where health systems research comes in. We need to break this market logic of inefficient models prevailing. We need to break a proprietary lock-in to inefficient models and try to unpack this miracle that seems to be occurring in small success stories that are happening. And I think this question, this sort of research where we try to understand why and under what conditions certain interventions work is most lacking and is what needs to be scaled up rather than the models themselves. And secondly, the concept of why things fail is something very unfashionable but something most critical and important in health systems research. And that really is my message to all of you, that we hope that we'll ask the right questions, however unfashionable it may be, however difficult it may be to answer, in the presence of severe gaps in conducting health research in the South. Under all these circumstances, the universal coverage agenda needs to progress, and I hope that you will all agree with me and join me in this discovery of the unanswered and unasked questions. Thank you very much.